And could you, Sabino, announce the next one?
Yeah, the next speaker is one of my friends. It's Alfredo Conti from University of Bologna, and he will talk about, the role of surgical approach versus radiosurgery for vestibular schwannoma. Please, I leave to you the stage, Alfredo.
Thank you very much. Can you see my presentation, my slides on the screen?
Yeah, perfectly. You can go ahead.
Thank you very much, Sabino. It's a great privilege for me. It's a great pleasure to be here on behalf of WFNS. And also, I want to say thank you very much to all the people who is listening to this seminar. And I'm sharing this presentation with my colleague from our center. Is a neuro-otological team for the management of vestibular schwannomas. It's also for me really important to talk about this specific topic, which is not only radiosurgery, but radiosurgery versus surgery. Why? I always believed, and I spent all my life, my professional life, basing my point of view on a patient-centered approach instead of a technique-centered approach, because any technique is destined to be surpassed while the needs of the patient are going to stay forever. Of course, the question is whether it is possible to combine skills in microsurgery, in skull-based surgery, and radiosurgery. I usually start my presentation on the topic showing this specific case, which is a quite straight case, nothing special. As you can see, it's a cystic schwannoma in 2 years. So there was a progressive shrinkage up to the disappearance of the lesion. So it's very positive result. The time interval is that we can expect from radiosurgery. It's a particularly positive result, but it's nothing special. It's something that can be achieved quite easily right now. But especially what I want to underscore here is the fact that this requires almost half an hour treatment and treatment planning and half an hour treatment delivery. And we have already some intelligent algorithms that allow us to do this in a semi-automatic way, semi-automatic contouring, semi-automatic planning, and robotic delivery. And this is possible not tomorrow, not the day after tomorrow, but just today. So this is something that we need to consider, because on the other side, to master this kind of surgery, a long-term practice is required. And you know very well that any complex ability of in human activities requires 10 years practicing, or 10,000 hours is something that is said everywhere, you can find everywhere. So this is the main difference, and it's something that we need to take into consideration when we want to be involved in radiosurgery versus surgery. So you can practice surgery while being aware of the potential of radiosurgery and being the protagonist, the main character in managing the patient, the pathology, not a technique. So I want to present, so I did this presentation mostly based on institutional data. So no literature review, but just institutional data. I'm going to show you radiosurgery results of surgical management, and results of surgery as a salvage treatment. And this is the radiosurgical series, 437 patients updated last year. In almost 2/3 of the cases, they were small tumors, COS 1 and 2. And you can see the other parameters. The dose to the schwannoma was below 13. Is getting lower and lower. We started 30 years ago with 15, 16 gray. Now we are even below 12, or between 11 and 12, but for sure lower than 13. My point is, my goal is 12.5. So tumor progression control. This is a personal series, institutional series is 0. You can see is above 90%. So this is one major point. Results of radiosurgery with vestibular schwannoma are extremely satisfactory, above 90% at middle to a medium to long term, which means after 10, 15 years, even longer in many CPS. And this is totally consistent with the literature. So results in vestibular schwannomas of radiosurgery are better than meningioma, better than pituitaryadoma, better than other pathologies like AVMs and so on. And also, we need to take into consideration that we have guidelines, and these guidelines have been produced by the most authoritative societies like CNS, IANO, or ISRS, which is the International Society for Radiosurgery. What they say, what these guidelines say, that for small tumors, I would say there, of course, are not guidelines. They are suggestions, recommendations for practice. But as a matter of fact, radiosurgery offers a better rate of hearing preservation and a lower risk of facial paralysis. This is also true for small tumors, for grade 1 with impaired hearing, for grade 2 with complete hearing loss. For medium-sized tumor, namely COS3 or smaller than 3 centimeter, surgery and radiosurgery can be recommended at a very similar level, but still radiosurgery has a lower risk profile. This is a really important point, and this must be discussed with the patient. So the patient must be informed that this is the perspective of treatment. For large tumor, of course, primary goal is decompressing the brainstem, what makes the surgery the only option, even though a combined treatment can be considered in some instances, not always, I would say. So it is possible to treat also by radiosurgery times to times also large tumors, but this is the difference in terms of tumor control. As you can see, COS1 and 2, which are the lines above, the tumor control is much better in smaller tumor as compared to larger tumor. This is one major point. Facial nerve preservation is close one. This is the second aspect. Close to 100%. I have to say, never seen one patient with a facial deficit after radiosurgery, provided that the dose is kept below 13 gray and we don't use margins around the tumor when contouring the vestibular schwannomas. This is a letter that I sent to the Green Journal, which is the main journal in radiation oncology field, and so I was criticizing the fact that there was one series from CyberKnife series in which the reported deficit after radiosurgery was very high, and the reason was that they used a too high dose, and they used the margin, 2 millimeters margins around the tumor, which means that they had the facial nerve inside the major dose, so with some hotspots directly on the facial nerve. So facial nerve preservation is possible only provided that the dose over the nerve is very low. Okay, this is another point. So going to the next point, hearing preservation. It is possible to preserve hearing. Generally speaking, I think that this is not really possible in the general population of the patient. You can see that the loss of functional hearing in the midterm is about 80% in this series, and this is not very much different from the literature in general. This is a meta-analysis from CyberKnife cases. As you can see, after 5 years, decline of the hearing was present in 50 to 75% according to the hearing classification, to the hearing function before treatment. The reason for that is that those to the cochlea, which is the most radiosensitive structure in the human body, should be kept very low, between 3 and 4 gray, which is too much low if we want to cover the tumor inside the internal acoustic meatus. Second aspect, in terms of complications, hydrocephalus. I want to show this case. This is a case of mine. It's a person that I know very well. This was treated. It's quite large tumor. It can be treated, no problem. It's there are cysts inside, so shrinkage can be expected in a few times. But this is what happens times to times. The patient developed hydrocephalus. What to do in a case like this? We can bring the patient to the operating room open the posterior fossa and resect the tumor. This would solve the problem of the hydrocephalus as well. It's a chronic hydrocephalus. This is very important. But let's say if we can manage the case, put a shunt, and we can wait for the shrinkage of the tumor, and the patient is doing very well. Cystic tumors, so large cysts, a real cyst, the true cysts inside the schwannoma can be treated. This is my opinion. This is a large tumor again, as I'm showing not the usual case, not the usual cases, but just some specific case, some particular cases. You can see the tumor shrinkage was possible as well. This is a failure. Sometimes failure occur, and you can see after treatment this was a postoperative recurrence. The tumor size increased, and this is quite usual. Let's say this is a pseudo progression. It's not real progression. At least we need to wait. But the point is that there was a pseudo cyst surrounding the tumor, and once after the treatment, these pseudo cysts surrounding, which are probably sequestration of the cister, can grow very fastly with the compression and symptoms. In this case, of course, surgery is required as a salvage surgery. So in conclusion, concluding for the part of the radiosurgical part, so radiosurgery provides tumor control in about 90% of the cases in long term. Okay, this is something which you can find everywhere in the literature. Hearing preservation seems possible in a small categories of patients, cause 1 or 2 so small tumors with very good hearing, and no brainstem or cranial nerves injury have been recorded in this series. Facial nerve deficits are considered below 1% probability, but it's very, very rare. Hydrocephalus is a quite common complication, but for hydrocephalus and pseudoprogression, urgent tumor resection, I believe it should be avoided. So this was the part concerning radiosurgery, but I want to compare these results with those of surgery. And then I am presenting results of a recently treated group of patients which were treated by microsurgery endoscopy by the neuro-otological team here of Bologna, Professor Prosutti, Carmelo Storiale, me, and other colleagues. So in the end, we collected 72 patients treated between November 2020 and March 2024. And here you can see the advantages of using endoscopy at the beginning or during surgery. So exploration and small surgical maneuver, the identification of the cochlear nerve, and mobilization of the tumor capsule after debulking. And you can see here the early visualization of the facial nerve. So another aspect which it is worth mentioning is the management of the intrameatal portion of the nerve with the concurrent visualization of the facial nerve. We know that the portion of the facial nerve is the most sensitive to maneuvers, to the surgical maneuvers. And of course, we can limit the opening of the internal acoustic meatus. We can manage the dehiscence of the bone to avoid the fistulas. And these are the results. This is the population of patients. As you can see, in this case, this series is specular as compared to that of radiosurgery. 2/3 of the cases were large tumors, grade 3 or 4. And these are the results. So facial nerve integrity anatomical integrity could be achieved in 87%. But as you can see, the goal of a surgery was gross total resection in all cases. So 100% of the cases underwent to gross total or near gross total resection. What happened after that? Transient neurological worsening was recorded in 12.5% of the cases. 9.7% had hydrocephalus, which is not dissimilar, not very much different from that I reported in the radiosurgery series. And this is about facial nerve preservation. Let's consider that in this series, 2/3 of the patient had a COS grade 3 or 4 schwannoma, and in patient who achieved at least 2 years follow-up, Haus-Brackmann grade 3 to 1 to 3 could be achieved in 78% of the cases. As you can see, all patients underwent rehabilitation at the discharge, which is very important, considered very important for us. And the facial nerve reanimation was done in 18% of the cases. So last topic, which is really interesting to me, which is surgery as a salvage treatment after radiosurgery. And this is a paper that has been published in 2020. So only 300 cases, 20 studies. So there is a real lack of high quality studies that analyze this topic. So this is the reason why a study has been organized. It's a multicentric retrospective study involving several major centers in Italy and some outside Italy. And in the end, 37 patients were included in this series. And as you can see, 90% of the patients had large tumors, grade 3 or 4, according to the COS grading system. So 54% of the patients underwent surgery because of tumor growth, not necessarily because tumor growing was associated to symptoms, which is something we can discuss about. And these are the results. So gross total resection or near gross total resection could be achieved in 2/3 of the cases. So much less than in the when using surgery as upfront treatment strategy. This is an interpretive finding reported by several surgeons, which is the arachnoidal adhesion to surrounding structures, something that has been described in the literature, is quite common. I have to say, I don't see any specific reason. What I personally found during surgery for salvage or for retreatment of schwannomas is that the tumor is less vascularized and usually more stiff than tumor at the first treatment. And these are the results for facial nerve preservation. It is 75%, which is not that bad considering the difficulties and the multiple treatments received by the patient. Anyway, is not far from the series from the series of the upfront surgery, and also considering that most of the patients were large tumors. So these are, I would say, a friendly way to consider treatment. So COS 1, probably observation if hearing deterioration, so moving to radiosurgery. For COS 2, if progression, surgery, or combined surgery and radiosurgery. This is, of course, another option. And of course, at the center remains quality of life of the patients, whereas symptoms may shift the treatment toward a surgical treatment, while frailty, as already proposed by Professor Mastronardi, should move the treatment choice to radiosurgery or radiation therapy. In conclusion, decision-making in management of vestibular schwannomas is totally controversial still today. Quality of life should remain the goal, and we stay close to the patient to help him to make the best choice for him, for his personal life condition, life situation, family, and especially for concerning their feelings about the disease. Radiosurgery, anyway, should remain part of the armamentarium of any skull-based surgeon. This is the main message that I want like to do. There are no radiosurgeons, there are no radioneurosurgeons, but there are no 0% complication surgeons. And one size does not fit all. Thank you very much for your attention.
Yes, yes, thank you. And now we move to Mustafa.
Yeah, sure.
To functional